Good morning, good evening, good afternoon. Today is Monday, and what do we do on Monday? We break it down. My name is Miss Rose, and we are here to break down blood and lymphatic disorder. All right, Mondays is our study group. Mondays is when we come together with pen and paper and your books and take some notes. So let's get started. Now, remembering A and P. And guys, you have to remember your A and P. I know you took it a long time ago and you don't remember hardly anything that was said in the class, but you got to go back to your A and P because if you don't know how the body functions or how the body is working, how are you going to treat the patient? How are you going to treat the patient? Okay, so remembering from A and P, blood transports oxygen to cells, right? Blood transports oxygen to the cells. It also removes waste products from cells and it delivers nutrients throughout the body. Now, the lymphatic system filters harmful substances out of the fluid, which would be the lymph fluid, that surrounds body tissues, and it also maintains fluid balance. So we need the lymph system, the lymphatic system, to help maintain our fluid balance within the body. Now, if the hemoglobin blood count is low, what is going to be the chain reaction? Based on based on what we just discussed, what is going to be the chain reaction? Correct. Less oxygen would be transported to the cells. There would be a slower breakdown and use of nutrients by the cell, and less energy produced by cells, and therefore decreased cellular function. So that was a whole lot. Now we understand the role of blood and lymph. When we start looking at some of these disorders, we can understand why they're having the signs and symptoms that they're having, right? Okay. All right, let's continue. All right. Now, when blood is sent to the lab and spun in the centrifuge, the components become apparent because they separate. Now, I like this slide. I found this on the internet. I like this slide, and it may be in some textbooks, depending on the book you use. But it shows the breakdown of the blood. The other thing, I just had a moment right there. But the other thing that I want to impress upon you is when we have these study groups, I am going to have to go over some A and P. So we'll always go over some A and P first, and then we'll hit the disorders. Okay. All right. So now we're going to look at the components so we have an idea of what the doctor is looking for when these tests are ordered. So the components of blood include red blood cells or the erythrocytes. These are the ones that carry the oxygen to and carbon dioxide away from cells. We have white blood cells, which are the leukocytes. Remember, the white blood cells do what? They fight infection within the body. Very good. But there are 5 different types, which we will discuss in a minute. Yes, there are 5 different types of white blood cells, and we're going to discuss those in a minute. Now, thrombocytes, those are also known as platelets, right? Those are the platelets, and those assist in forming clots. And then we have plasma. Plasma is where you find mostly water, some important proteins, and other solutes like waste products, nutrients, gases, and regulatory substances like hormones. Now, plasma accounts for 55% of blood. And what is the main component of plasma? Water. That's right, water. This is why we tell our patients to drink what? Water. This is not why we're pushing juice. We're not pushing cola or soda or pop, depending on what part of the country you live in. I'm in the Midwest, so we say pop. Um, We push water. We encourage water because that is the main component of plasma. It also contains proteins like albumin. Albumin is huge. Look at that. It's 54% of the proteins that are contained in the plasma. Okay. We're going to talk about albumin in a minute. But we got albumin, we have nutrients, we have electrolytes, we also have hormones and gases. All of those are found in plasma. Plasma proteins play roles in blood clotting. They play a role in the immune system and the regulation of fluid volume. Plasma without clotting proteins is called serum. Okay? Plasma without the clotting proteins is called serum. SERUM. Now, light bulb should have gone off when I said the main component of plasma is water. hmm Our body needs water, not juice, smoothies, or coffee. We need to be drinking water. Okay. Now, erythrocytes. Let's break this down. Erythrocytes are the red blood cells or the RBCs. Leukocytes are the white blood cells or the WBCs, and platelets. They make up about 45% of blood. RBCs are the heaviest of the formed elements um, because I don't think I mentioned this, but the whole blood contains plasma and formed elements. Okay, so we just broke down what we could find in plasma. Now we're going to look at what we find in the formed elements. Okay, so again, um, RBCs are the heaviest. RBCs are the heaviest of the formed elements, and they sink to the bottom of the sample. So this percentage of RBCs in a sample of blood is called the hematocrit. That's where we get that from. I know you heard of H&H, hemoglobin and hematocrit. That's where we get the hematocrit from. It is the percentage of red blood cells in that sample of blood that have sunk to the bottom. And you can see them on this slide here at the bottom. You see the formed elements and you see the red blood cells being the heaviest sinking to the bottom. Okay, WBCs and platelets, they form a narrow buff-colored band just underneath the plasma. They call that the buffy coat. And these cells constitute 1% or less of the blood volume. And they all, and all they are is the concentration of all the white blood cells and platelets in the blood. NCLEX won't test you on this, but this is the type of background information that you need to know in order to think critically when considering the answers to the questions you may be asked. Okay? So it's not going to ask you what's the white band. It's not going to ask you that. But you need to know what that white band is. When blood is drawn from a different for a differential, like um, the doctor might order a CBC with differential. Okay, so when blood is drawn for a differential, the doctor wants to know the percentage of blood cells in the body. That's all. He just wants to know the percentage. Will you need to know the normal lab value for these cells? Probably not. NCLEX will include the lab values and the ranges within the question. They didn't used to do that. You used to have to memorize those values, but now they're because values can vary depending on the place where you work, depending on the textbook that you use. Um, they've decided to just include the lab values and the ranges when they talk about it in a question. However, you do need to know at least, at minimum, the range. Okay, you need to know some normal ranges so things don't just sound outrageous. Okay, so you need to have an idea of what each type of cell does as well. Okay, all right, let's go to the next slide. So here is the breakdown of white blood cells. Remember we said there were 5 different types. Most common and the body's main defense from infections. Um, by killing bacteria, fungi, and foreign debris are our neutrophils. The neutrophils are the most common, all right? And after the neutrophils, and I'm just going over this briefly, you can always go back to your AMP book if you need to go in a little bit more depth. Um, lymphocytes. Lymphocytes consist of T cells, the natural killer cells, and B cells to protect against viral infections and produce proteins to help you fight infection. Those proteins are called antibodies, right? Then we have the eosinophils. These identify and destroy parasites, cancer cells, and they assist the basophils with your allergic responses. Mhm. Do you see how this background information? So a lot of times people think that you can just, you know, do practice questions and get the rationales and then you study. But it's really, really, really important that you understand some of this content. You need to understand some of this content. All right. So now let's look at the basophils. Basophils produce an allergic response like coughing, sneezing, or runny nose. Monocytes defend against infection by cleaning up damaged cells. All right, so those are the 5 different types of white blood cells. Now let's talk about hemostasis. Now, not homeostasis, but hemostasis. What is hemostasis and how does it occur? Well, hemostasis is a protective measurement within the body to keep us from hemorrhaging. All right. So let's look at the process here. The process um, involves vessel spasms, platelet plug formation, and clot formation. Again, this is important to know because if your patient is taking something that will interfere with this process, what do you think will happen? What do you think will happen? That's right. They will bleed out. Very good. Meaning they will hemorrhage. Okay. So let's look at the process. Vessel spasms. Smooth walls of the vessels. We're talking um, veins and arteries. We're talking about the vessels. Smooth walls of the vessels contract. This narrows the lumen of the vessel. So when the lumen narrows, we call this vasoconstriction. Now, why does it do this? Why do you think why do you think the body is doing this? To keep us from losing a lot of blood initially, right? So you cut your finger, paper cut, whatever, you cut your finger, and the smooth walls within that vessel are going to contract, which means it's going to narrow. The more narrow the vessel, vasoconstriction, the less blood can flow out of that vessel. That's why the body is doing that, is trying to protect us. Okay? Now, platelet plug formation is next. Platelets rush in and attempt to seal off the area, right? The vessel has constricted, so there's not a lot of blood being lost. And the platelets are coming to that area to seal it off and form a clot. Okay? This is effective in most small vessels. The larger the vessel, though, the harder it is for this process to maintain hemostasis. Okay, so it just depends on which vessel is cut. But if it's a small vessel, then this is fairly you've experienced it. You've cut your finger and it's stopped bleeding. But the larger the vessel, if you cut like your arm or something, a bigger vessel, it's going to take a little longer to stop that bleeding. Okay. So, and then finally, we have clot formation. All right, next is our lymphatic system. Lymph vessels collect lymphatic fluid, which consists of what? What is in the lymphatic fluid? There is water, mhm, protein, fats, and wastes from cells. They transport this fluid to the lymph node. Now, this is a picture of a lymph node, anatomy of a lymph node. Not going to go too much into that, but if you look at this lymph node, what does it resemble? What does this thing resemble? It looks kind of like a kidney, doesn't it? Looks a little bit like a kidney. All right. So, what happens next as this fluid is transported to this lymph node? What happens next? Well, next, waste and foreign materials are filtered out of the fluid. It's filtered out of the fluid. The fluid is then returned to the circulatory system, okay, where the red blood cells and everything is. This helps to maintain fluid balance within the body. The lymph node, again, has a remarkable resemblance to the kidney, and it also filters the lymph fluid as does the kidney filters the blood. Isn't that interesting? Look at the body. Look at the body. All right. So remember, we just said that lymph fluid helps maintain the fluid balance because the fluid is returned to the circulatory system. Well, if the fluid does not go into the vascular system, but instead accumulates in the interstitial spaces, the patient will have a condition known as lymphedema. Very good. This is lymphedema. Um, I found this picture on the internet as well. But there's a picture of the leg that's affected with the lymphedema. Remember, this fluid didn't go back into the circulatory system. And when it goes back into the circulatory system, what do you think we do? What do you think we do with it? We urinate it out. Okay, it's going to get filtered through the kidneys and it's going to be made into urine. So, but this didn't make it back into the system, so now it's collecting in the interstitial spaces. Now our patient has edema, but it's lymphedema. And again, this one is a picture of the arm. So it affects extremities. It could also, usually you can see it in extremities, but it can be anywhere where there's interstitial spaces. Okay. So lymphedema, what are the ways that the patient can avoid trauma, right? Because our interventions include increasing the lymphatic drainage. We want to get that lymph fluid in the circulatory system, and we want to avoid trauma. So when you see that, you have to think, well, what are they talking about? Avoid trauma. They're not talking about, like an accident or something like that type of trauma. They're saying that we need to be practicing good hygiene and protecting the skin. We don't want these people to get cuts or bruises because why? They can become infected. Very good. So, nursing interventions include massage, encouraging active exercise, instructing on proper use of compression garments or devices, and ensure that they are properly fitted. So those compression garments and devices is going to actually um, um, reduce the swelling or the edema from the fluid and kind of get the fluid to go back into the circulatory system where it can be filtered through the blood by the kidneys. Okay, let's look at anemia now. Anemia is commonly defined as a reduction in RBCs. And RBCs, fancy word for RBCs is what? Erythrocytes, okay? If there's a reduction in RBCs, there's going to be a low hemoglobin. That's going to result in a low hemoglobin. Remember the hemoglobin? That is the oxygen carrying element of the red blood cell. If there's not a lot of red blood cells, the body won't get the much needed oxygen at the tissue and cellular level because it doesn't have enough hemoglobin for the oxygen to attach to. Okay? There are different kinds of anemia, different types of anemia, and we're going to discuss each one of these on this slide. We have the hypovolemic anemia, pernicious anemia, aplastic anemia, iron deficiency anemia, and sickle cell anemia. So let's start with hypovolemic anemia. So what can cause blood loss other than an injury? See, everybody doesn't bleed or hemorrhage to have this hypovolemic anemia. So there's other ways we have blood loss. And what are those? Bone marrow depression. How about that? Bone marrow depression, which would impair the production of RBCs, because where are RBCs made? They're made in the bone marrow. RBCs are not like the other cells where they divide and keep dividing and making more and more. No, RBCs are made and RBCs die. Okay, so we have to remember that. Remember, red blood cells are made in the bone marrow and they die after about 120 days. So the body, under normal conditions, is always making or manufacturing red blood cells to replace those that die. And this happens in the bone marrow. Destruction of red blood cells, we call this hemolysis, and this can occur from cancer, right? So we have a situation where the bone marrow is not making enough red blood cells. We can have a situation where red blood cells are being destroyed from cancer, an overactive spleen, or some other autoimmune disorder that sees the red blood cell as a foreigner and destroys it. So in hypovolemic anemia, there is a loss of blood volume. There's a loss of blood volume. A decrease in blood volume will affect the heart rate and the blood pressure. In what way? In what way? Okay, I'm gonna give you a second. Let's look at this. Signs and symptoms. Now, they will include restlessness, a subtle rise in respiratory rate, weakness, stupor, irritability, pale, cool, moist skin, and a rapid thready pulse. So how will it affect the heart rate of blood loss of blood volume? How will it affect the heart rate and the blood pressure? I want you to think about why there would be a subtle rise in the respiratory rate. Think about that. We're gonna think about a lot of stuff here. Because remember when I told you that if you understand how this stuff is working in the body, then you will be able to understand the signs and symptoms, why they're having these. Well, if there's a decreased oxygen, if there's decreased oxygen due to decreased red blood cells, due to the lack of hemoglobin for the oxygen to attach to. That's why there would be a subtle rise in the respiratory rate. Okay? How would it affect I think we asked about the blood pressure and the heart rate, right? Okay, so we got blood loss. That means we don't have a lot circulating. So if there's not a lot of blood circulating in the system, then the heart has to pump this little bit of blood around to all of the major organs. So you're going to see an increase in the heart rate, right? And if there's not a lot of volume, then that means there's not a lot of pressure. Blood pressure will be a little lower. Okay? All right. So just remember that. Nursing interventions include monitoring your labs. What labs are you looking at? You're going to be looking at the CBC, the complete blood count, and you're going to be especially focusing on the red blood cell, hemoglobin, and hematocrit, right? I think I got something else on this other slide here. I'm not sure. So let's just keep going. If the patient is bleeding, you want to stop the bleeding and replace the fluid that's been lost. Remember what we said about blood. Blood is made up of what? Plasma and formed elements. All right. And what is in the plasma? Water. So you have to replace the fluid. I believe I have something else on this slide. I thought so. Um, So the blood count should be monitored during and after the suspected bleed. And if there is a suspected bleed, we want to stop that bleeding. Usually we're going to replace the fluids with an IV, right? Okay. Hemodynamic status. What is that? Hemodynamic status. That is a fancy term for monitoring blood pressure and vital signs. Okay. So if you ever hear the term hemodynamic status, monitor the hemodynamic status of your patient, they're telling you need to be doing some vitals and looking at the blood pressure. That's what they're saying. Okay. All right. Very good. I think that's all we have here. Okay, so let's move on. Next slide. Hypovolemic shock. We're talking about hypovolemic anemia. So we got this blood volume, this loss of blood volume, then that person can go into a hypovolemic shock. So if there's a decrease in the circulating fluid in the body, a person can go into shock. And we just said that hypovolemic anemia is a loss of volume. So with this loss, the patient may be irritable. They may have some weakness, cool and clammy skin, diaphoresis, and a weak, thready pulse. Weak, thready pulse. Remember that with hypovolemia, because why? It's not a lot of volume. So if you were asked which symptoms were neurological symptoms, which would you choose? Off of this slide right here. Of these signs and symptoms right here, which would you choose? Okay, hopefully you'll choose irritability. Irritability is a neurologic sign. So let's look at these symptoms and others and the treatment. I love this picture. I found it on the internet. This is a clinical picture of a patient in hypovolemic shock. All right, so if we look over here, let's start over here on the left. Altered mental status, neurological, usually first signs, right? These are early signs. You have restlessness and disorientation may be present, right? Then look at the heartbeat, tachycardia, rapid heartbeat, dyspnea, right? They're having difficulty breathing or shortness of breath due to blood loss and the lack of the red blood cells which carry the oxygen. Then we have cool, clammy skin due to the blood loss again. In this picture, there's obvious bleeding. So we don't, I mean, this is a hemorrhage. Person maybe have been in an accident or whatever, but there's an obvious bleed, not a bleed from a cancer or something destroying red blood cells. Go back over here on the left, there's hypotension. That means there's a drop in the blood pressure because why? There's decrease in blood volume. Let's look at the yellow bag right here. They have a urinary catheter and there's decreased urinary output due to what? Low blood volume. So if there's low fluid volume, the kidneys in all its infinite wisdom is going to hold on to any fluid. It's not going to you won't be our patient won't be urinating. It's going to hold on to all the fluid. The kidneys recognize we need to keep the fluid in the body. All right, so now let's look down here. We have IV fluid replacement and a blood transfusion. Okay, so fluid replacement therapy for the patient in hypovolemic shock or with hypovolemic anemia is necessary to reverse these signs and symptoms. Okay, all right. So the urine output is going to be less than 400 mLs in a 24-hour period. Now, when would you anticipate the doctor to order a blood transfusion? That may be a question. When do you anticipate the doctor to order a blood transfusion in a patient with hypovolemic anemia? When the hemoglobin falls below 7 grams per deciliter for patients in ICU and 8 for post-op patients. That's usually the recommendation. Okay. All right. Now let's look at these interventions and we want to keep this patient flat and warm, right? What are we taking into consideration when they say keep the patient flat and warm? Shock, right? So in early stages of shock, you see a heart rate of less than 100 and a normal blood pressure. But as that blood loss increases, remember we said cool, clammy skin? So as the blood loss increases to more than 100 mLs, the blood pressure will decrease. It'll start dropping. So monitoring the blood pressure and other vital signs would be crucial because we want to keep the systolic BP greater than 90 millimeters of mercury. All right. A blood loss, as the blood loss increases more, the systolic pressure falls to less than 90 millimeters of mercury, and the pulse increases to more than 120. So when you have a low blood pressure and a high heart rate, we call that shocky. Your patient is looking a little shocky. Okay. Blood loss of 2,000 to 2,600 mLs results in irreversible end organ damage or organ failure. This is where monitoring eyes and nose comes in because we want to make sure the kidneys are being perfused. And how do we know this? How do we know the kidneys are being perfused? Urine output at or greater than 30 mLs per hour. Very good. Very good. All right, now let's look at some blood types. Blood typing or grouping is the ABO system. Okay, that is the preferred system for the four types, and they are A, B, AB, and O. So this slide tells you why we must make sure our patients get the proper blood type. We've got four we got four types, and each type contains antigens and antibodies. So let's look at type A. Type A, it contains the A antigen, and this type of blood would clump together when it encounters blood that has the A antibody. Types A, B, and O are special because type AB has no antibodies, so they can receive any blood type, and type O does not contain any antigens, so they can give blood to anyone. All right. So AB is what we call the universal recipient. They can receive any blood. And type O is what we call the universal donor. They can give blood. Okay. Anybody can receive this blood. All right. Let's look at megablastic pernicious anemia. Um, Megablastic was the older term. Now it's called pernicious anemia. Um, and if that goes untreated, it can be fatal, meaning your patient can die. Pernicious anemia is where the body is not absorbing vitamin B12, okay? It's not absorbing vitamin B12, and B12 is needed for the growth of all body cells, including RBCs and bone marrow. So without B12, there is destruction of the myelin, which is covering some nerve types. And when we start talking about neuro diseases, um, we're going to be talking about the myelin. Okay, so there's degeneration of the myelin in white matter. Okay, intrinsic factor is needed to absorb B12. And where do we find, see again, this is AMP. Where do we find intrinsic factor? Yeah, it's found in the stomach lining. And without it, you can't absorb B12. So if you eat something with B12, your body won't be able to absorb it. So the treatment is going to be what? How do we get B12 into these patients? It's going to be by injection, right? They're going to have to take B12 injections for life or sublingual. Okay, so now let's look at some of these signs and symptoms of pernicious anemia. Fatigue. Why fatigue? It's like we said at the beginning, decreased hemoglobin, Okay, we just said it, and it should be in your notes. Decreased hemoglobin. Hemoglobin carries oxygen. If you don't have the hemoglobin to carry the oxygen, you're not getting oxygen to those tissues, you're going to be tired. Okay. Um, what else we have here? Glossitis. Glossitis is inflammation of the tongue, and it gives it a glossy look. Okay. And then again, there we got decreased hemoglobin. So when a patient has had, think about this, when a patient has had gastric bypass surgery or gastrectomy, there is a risk of megaloblastic anemia from a decrease of the availability of intrinsic factor. They have removed some of the stomach. So they've removed the lining that produces the intrinsic factor. Think about that, guys. So this is something that we nurses, we should be aware of this, okay? Now let's look at, again, treatment involves replacing the B12 with injections or sublingual, right? So when we take medication sublingual, if you recall, it gets absorbed right into the bloodstream, okay? Or they can get shots, either one, but they can't eat it. I mean, they can eat it, but it's not going to be absorbed as readily. So nursing interventions vary greatly and are dependent on the patient's condition. Okay. All right. So patient teaching for pernicious anemia. I want to bring to your attention a couple of points on this slide. One is bowel color. So the importance, we want to teach them about the importance of maintaining their B12 level because why? We need it for what? All cells. We need it for the nerve cells. Okay. Um, the patient should be taught how to self-inject or a family member if they are having to take the injections. Oh, balanced diet. Balanced diet high in protein, um, vitamins, and iron. Okay? Proteins, vitamins, and iron. We also want them to monitor their bowel movements, noting the color, consistency, and amount. So, bowel color can tell you a lot. Bowel color can tell us a lot about our patient. You can Google a poop chart. Yes, I said poop chart and see what I mean because they got a chart of poop and what each color represents. So if the stool is dark or tarry looking, this could be a sign of bleeding in the GI tract. Which would what? Which would indicate old blood, right? Dark and tarry means old blood. Bright red means new, fresh blood. And two, we want to teach ways to avoid fatigue. How can we avoid fatigue? And you probably won't even think of this. But one way is by encouraging 6 small frequent meals. You say, how is that, Miss Rose? Well, you know how you feel after you've eaten a big meal? Yeah, you're tired, right? Okay. So that's how we can avoid fatigue. And of course, um, performing ADLs and, providing some rest periods between activities. Okay, some diagnostic tests could be the Schilling test, the CBC, bone marrow aspiration, and gastric analysis. But of the diagnostic tests listed, the bone marrow aspiration biopsy is the one I want to focus on because this test involves taking a small amount of bone marrow fluid, what we call aspiration, or solid bone marrow tissue, what we call a core biopsy. And they are checked for the number, size, and maturity of blood cells or abnormal cells. But the reason I want to look at it is because we as nurses play a role in assisting with this test. Okay? We play a role in this. And you will need to know your responsibilities as it relates to this test. Um, Pressure is applied to the aspiration biopsy site, and it needs to be observed for bleeding. Watch for symptoms of infection and report any arrhythmia or tenderness to the doctor. Arrhythmias is a fancy word for what? Redness. Okay. Monitor for signs and symptoms of shock, which we already identified as an increased pulse and a decreased blood pressure. Keep this patient on bed rest for 30 to 60 minutes after they've had this bone marrow test. The doctor may order the patient to be NPO for several hours after the test to avoid nausea and vomiting. The site may be painful for several days and the patient may require analgesics. This is where your patient teaching comes in, and this should be done prior to the actual test. Okay, so you may get a question about patient teaching for bone marrow aspiration, and one of the things you need to tell them is it's gonna hurt. It's gonna hurt, and they need to know that. Be aware that the complications to watch for from this procedure are hemorrhage, infection, symptoms of accidental puncture. Doctors aren't perfect. They may accidentally puncture something that's near the structure nearby, especially if the test was done on the sternum, because there's certain um, sites that the doctor will use to um, do this bone marrow aspiration, and the sternum is one of those sites. What's close to the sternum? What does the sternum sit in front of? What's behind the sternum? Yeah, a whole bunch of stuff. The heart, great vessels. So you have to watch for symptoms of accidental puncture of the mediastinum and fracture and inadvertent puncture of the heart or any of the great vessels if the test is done on sternum, right? Okay, very good. Where are we at now? Aplastic anemia. Aplastic, now that was pernicious. We're on aplastic, all right? Aplastic anemia can be congenital or acquired. What's the difference? What is the difference? Congenital means what? You're born with it. Very good. You're born with it, while acquired means you developed it, right? Okay, very good. Um, Aplastic anemia is depression of the erythrocyte production, which results in lowered hemoglobin in red blood cells. Leukopenia and thrombocytopenia may develop, and the patient is usually pancytopenic. Pancytopenic. What is that? What is that fancy word? The patient has low blood cells of every kind, white, red, platelets, whatever, and presents when there is damage to the bone marrow. Okay. Now, we want to look at signs and symptoms. Okay. And tell me if any of these look familiar. Fatigue. Remember, we're still talking about different types of anemia. So the symptoms are going to be similar or they're going to be the same. So we've got weakness, fatigue, general malaise. Here we go with respirations, dyspnea, palpitations, cardio. All of these are may be characterized by aplastic anemia. Okay. Blood that is infused contains iron. So let's look at the diagnostic. This is diagnosed through history, right? They're telling the doctor about their signs and symptoms. It's diagnosed through a CBC and a bone marrow biopsy. There's that bone marrow biopsy again. You need to understand your role in the bone marrow biopsy or aspiration, and because there's always test questions on that topic. So the treatment again would be the blood transfusion, which must be used cautiously. There would be steroids on board. There would be immunosuppressant therapy, also maybe a bone marrow transplant. And our job is to prevent infection because look at all of this. So what do you see? Steroids, immunosuppressant, um, bone marrow transplant, all these things putting our patient at risk for an infection. We're taking out their fighting mechanisms by giving them steroids and immunosuppressant. They're immunosuppressant. We're suppressing the immune system. So we have to watch out for infection. Now, blood that is infused contains iron. So if you remember from your A&P that not only does oxygen attach to the heme of a RBC, red blood cell, iron binds to the heme as well. And I'll go a little further. Carbon dioxide binds to it too. So there's different binding sites on the heme which accept these different elements. So the body can develop antibodies to uh, the transfused blood, making it less effective. But the other thing that you got to remember is iron is a metal. So while you're infusing iron, this can become toxic to the patient. So that's why transfusions are used cautiously because we don't want to, because the iron, again, is a heavy metal and it can cause organ damage, not just to the kidneys, but also to the brain. So you have to remember that. We do have medications, though, that can remove the iron. Once it's in the body, we can bind to the iron and remove it. But again, we just have to be cautious. Now, there's also something called, I don't see it on the slide. It's called hematopoietic cell transplantation or HCT, bone marrow transplantation. That's the treatment of choice for patients younger than 50 years old. Okay. Question. How does a bone marrow transplant help in treating aplastic anemia? How does bone marrow transplant help in treating aplastic anemia? Red blood cells are made in the bone marrow. So if we give a bone marrow transplant, we can get new red blood cells hopefully being manufactured. Okay, very good. Next, we have some interventions. I think we talked about some of them, but it's to prevent infection. We have to. We must use good hand hygiene, good oral hygiene, and avoid contact with those who have an infection. Again, these people may be on immunosuppressant therapy due to the bone marrow transplant, right? We don't want them to reject the transplant, so we give them immunosuppressant therapy or multiple blood transfusions. And don't forget the steroid therapy that's on board, okay? So we want to observe for signs of blood in the urine or the stool and something called petechiae. We want to avoid enemas, rectal temperature, picking the nose or blowing the nose forcefully. We don't want them using electric razors because we don't want them to risk being. I mean, we want them to use electric razors because we don't want them to risk being cut by a safety razor, and we want to avoid aspirin because aspirin does what? What does aspirin do? Aspirin is an anti-platelet, anticoagulant medication, which will prevent them from bleeding. I mean, prevent blood from clotting. Decrease platelets due to bone marrow depression as well. Okay, so we don't want them bleeding. They have already have decreased platelets due to the bone marrow depression. Again, we see prevent fatigue. So that's what? 6 frequent small meals and clustering activities if the patient is in the hospital. Okay, that means we don't want to go in a room moving them around 5 and 6 times. We just want to go in, do some things, several things, come out, leave them alone, let them rest. Diagnoses, and we haven't looked at diagnoses, but diagnoses for our anemias can be activity and tolerance related to inadequate tissue oxygenation, right? Low hemoglobin, not enough tissue for oxygen to attach to bind to the hemoglobin. And they can also be at risk for infection related to increased susceptibility because why? We're giving them immunosuppressant drug therapy. They're not making a lot of white blood cells. Okay. Very good. Now, let's look at iron deficiency anemia. I want to look at some medical terminology right now, though. The prefix normal, Normo, refers to normal. The suffix site refers to cells. Let me see. Where's my pen? I think I want to write something down here. Nope, not that one. This one. Okay, so we have normal. I'm gonna write it up here. N. Ooh, look at my writing. ORMO means normal. Site. What does site mean? CY. That's a Y. TE. Site means cells. Okay, site means cells. Chrome. That's another word. Chrome. CHROM means what? That refers to color. And then we got the suffix ic. 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 That means having the quality of, having the quality of, or characterized by. So when we see hypochromic, hypo meaning what? Low, decrease. Chromic meaning chrome means what? Color. And ic is what? Having the quality of or characterized by. So hypochromic, microcytic anemia, that was a mouthful, is characterized by decreased levels of hemoglobin with not enough color and small micro cells. This type of anemia is typical of an iron deficiency anemia. Okay? Hemoglobin is needed for oxygen and iron molecules to bind to. Remember, we need hemoglobin for oxygen and iron molecules to bind to. Now, the most common symptoms of iron deficiency anemia are pallor, pale, right? Pale looking, glossitis, um, fatigue, weakness, and sometimes shortness of breath, all related to the same thing. RBCs, hemoglobin levels, and hematocrit levels are decreased. Serum iron levels are low. The treatment is aimed at iron replacement and stopping any bleeding if there's bleeding involved. Now, if a person has anemia, it will manifest physically. And here you can see in the top left picture what we call spoon-shaped nails. Spoon-shaped nails. Now, the nail on the right is a normal nail, but the nail on the left is a spoon shape. So it has like a little crater. Okay. Next to that is a picture of vertical ridges in the nail. Vertical ridges. We can see vertical ridges in a person with anemia. Also at the bottom, you can see the tongue. You see glossitis. See on the side of that tongue right there has glossy. And so that just means glossy um, tongue, glossitis. I want to also mention that the nail bed can be pale instead of pink, right? It's not pink if anemia is present. So when you go to do your capillary refill, you'll notice that it's not pink. It's not pink, but it might be pale color instead. So treatment and nursing interventions, we want to instruct our patient to take the oral form of vitamins, I'm sorry, of iron supplements, ferrous sulfate. Ferrous sulfate is often required, and we want to take that with orange juice or other vitamin C rich foods, ascorbic acid, vitamin C. That helps with the absorption of the iron. Okay. Food sources include what? What type of food sources do we want them to include? Those high in iron. And we also want them to increase fluids and roughage, right? Fluids and roughage. What is roughage? We want roughage for what? Fiber. Roughage is for the fiber. And we want them to eat those foods because why? Because why? To avoid constipation. Right. We don't want them getting constipated. Iron causes constipation. And if any of you have ever taken iron supplements, you know that they cause constipation and dark stools. Okay? All right. So, um, since we mentioned food sources, you need to be knowledgeable of food sources high in iron because you can get a question that asks you which diet is best. And they will give you food options for each choice, and you will have to choose the best answer. So, this is also part of our patient teaching. We do a lot of patient teaching. This would be about nutrition and diet choices. Okay. Now, these drugs prescribed may cause GI upset. What is that? Nausea, diarrhea, constipation. And we need to be monitoring for constipation. That's the big one. Um, Tell patient that oral form of iron will turn their stool black. They need to know that so they don't call the doctor saying, my stool is black. Oh my gosh. Okay, they need to know that. That's part of the patient teaching. Do not give them milk. Why don't we give them milk when they're on these drugs, on these supplements? Because it decreases the absorption of the medication. Now, there's a drug down here called dextran, iron dextran. Another test question. Always. How is this drug given? How is dextran given? This is usually a test question because it's a matter of safety. So, how is iron dextran given? Does anybody know? Okay, if you said I am using the Z-track method, you are correct. Very good. Um, Signs and symptoms that should be reported, diarrhea and nausea. Even though it is expected, it's an expected side effect, it still needs to be reported. Okay? All right. Okay. Do you guys need a break? Okay, you can just pause it and come on back. Um, or if we live, you can't pause it. You just run and get you something. But the other people, you pause it and come back to it. Now let's talk about leukemia. Leukemia literally means white blood. Literally means white blood. It is a cancer of the bone marrow which produces WBCs. There are several types. But I want you to know that the ALL affects mostly children. Okay? Now we know that the white cells are a large part of our immune system. In leukemia, these white cells are immature. They're immature. So it's a malignant disorder of the hematopoietic system in which an excess of leukocytes accumulates in the bone marrow and lymph nodes. And it's classified by the type of cell involved. Okay. Um, so the white cells they don't mature and leave the bone marrow like they're supposed to, thereby impairing the production of healthy cells. Leukemias can be chronic or acute. Diagnosis, signs and symptoms. Patients with chronic leukemias are often asymptomatic, and the disease is usually detected during a regular physical examination and a routine CBC. Okay. Diagnosed through careful assessment, lab, CBC with differential because why? We want to look at the different types of cells, right? We want to look at, remember, there are 5 different types of white cells. So we want to look at the count and bone marrow studies to rule out other disorders. Patient may initially complain of bone or joint pain and fatigue. Okay. S- Uh, Symptoms can progress to skin abnormalities, frequent infections, usually flus and sore throats, and abnormal lab findings. Other symptoms may include fever, headaches, pallor, weakness, malaise, swollen lymph nodes, enlarged spleen, and easy bleeding. or thrombosis. So again, you gotta think safety by preventing infection and bleeding with these patients. Major effects of leukemia is increased numbers of abnormal, immature leukocytes. These leukocytes can't fight infection. They're immature. They're not big kids. They're little kids. They can't fight. Accumulations of these cells within the body, and ultimately infiltration of the malignant cells throughout the lymph nodes, spleen, and other organs. Okay, those are the major effects of leukemia. The treatment again is chemotherapy, HCT, we mentioned that earlier, but the main goal here is slowing down the growth of these malignant blood cells. These are cancer cells, and you know cancer cells replicate quick. So you want to slow that growth down. Maintain a normal level of RBCs, hemoglobin, and platelets, because these are necessary to stop bleeding, to carry oxygen and nutrients to the body. Managing the symptoms and meeting the special needs of each patient. Exploring curative therapies such as HCT, the hematopoietic cell transplantation, or HCT, a bone marrow transplant. Okay. Leukapheresis. Leukapheresis is the separation of WBCs, which can be done to reduce the massive number of circulating leukocytes that's clogging organs and causing damage. In this treatment, blood is drawn, the unwanted white blood cells are separated out, and the remainder is returned to the patient. So it's a process similar to hemodialysis. Antibiotics may be given prophylactically during chemo, and because the body's immune system and the ability to fight off any infection is seriously compromised. Seriously compromised. Okay, very good. Now, what do we need to consider? We need to instruct the patient to eat cooked foods because raw foods contain bacteria that could cause infection. Diligent hand washing, meticulous oral care is warranted. Also, we want to monitor their temperature, and anything over 100.4 degrees Fahrenheit or 38 degrees Celsius that lasts for more than 4 hours can indicate an impending infection. And one more thing that you probably did not consider, have the patient deep breathe every 2 hours while awake. Okay, deep breathing every 2 hours while awake. We want to get as much oxygen um, as we can in the body. Okay, chemotherapy not only compromises the immune system, but it also makes them tired. So we want to encourage rest between ADLs. In nursing, we encourage independence, you know that, and we let our patients do as much for themselves as possible. But when chemotherapy is on board, we want to assist where we can. Okay, we want to help out. These patients have the potential to bleed because of the decreased platelet count. So we need to monitor platelet counts. This is safety. If they are experiencing any oozing of blood, especially from the gums, they need to report that. A soft toothbrush or swabs may be suggested. Also, we need to be avoiding constipation because the straining can cause bleeding and hemorrhoids. Safety. Electric razors instead of regular safety razors to minimize cuts. Now, let's suppose that this patient is the breadwinner, the breadwinner, or the only one in the family working. Or this could be a two-person family income that now has to survive on one income. Coping. Now we're talking about coping. We will need to refer them to resources to assist them and help them cope with the new family dynamics. Remember, this is nursing. We take care of the whole patient. We take care of the family and society, community. Okay? It's not just the patient. Okay. We're going to look at disorders of coagulation now. Okay? One of the ways the body maintains hemostasis is through the clotting of the blood or coagulation, right? If not, we just bleed. Every time we cut ourselves, we just bleed to death. So the body has a system in place to stop this from happening. But disruption to this process can be vascular, it could be platelet dysfunction, or an alteration in plasma coagulation factors. Now remember, I'm just saying FYI, in case you don't recall from your A&P, the liver is responsible for making some of those clotting factors. Okay, just saying. A disorder can be congenital or acquired, secondary to another disease, or it could be from medication toxicity. So let's take a look at some disorders of coagulation, and I'm going to take a sip of tea. Okay. These are three common disorders of coagulation. They are thrombocytopenia, hemophilia, and disseminated intravascular coagulation. Thrombocytopenia, let's start there. This is the deficiency in the number of circulating platelets, medications like nonsteroidal and anti-inflammatory drugs or our NSAIDs, thiazides, can result in platelet deficiency. Heparin triggers antibodies that stimulate platelet activation, resulting in formation of clots and depletion of platelets. So it occurs in aplastic anemia, leukemia, tumors, and chemotherapy. Major signs include petechiae and ecchymosis under the skin. So ITP, ITP is in Paul, or immune thrombocytopenia purpura, which only means purple spots or patches. We got fancy words for simple stuff. Purple spots or patches is immune thrombocytopenia purpura. It is an autoimmune disorder where the platelets are covered with antibodies. In the spleen, these platelets are seen as foreigners and destroyed. Remember, if the body doesn't recognize it, it destroys it. They may also have these large bruised areas called ecchymosis. Ecchymosis is large bruised areas. Petechiae are like um, pin size um, red dots that can be seen on the skin or most commonly in the conjunctiva. Okay. So, patients may also vomit blood, have black tarry stools, and passage of red blood from the anus. Okay. This is diagnosed through lab testing and careful assessments. Now, you're going to be looking at labs, right? I said lab testing. You're going to be looking at labs. Which labs are we looking at? Which labs are we looking at? CBC, because we want to look at what? The platelet count. We said this was a platelet issue. Okay. Treatment is aimed at the underlying cause. Frequently includes administration of immunoglobulins. Nursing interventions, again, preventing infection and preventing bleeding. We got a couple of drugs that have been approved by the Food and Drug Administration, and it prevents the spleen from destroying these platelets, and it's called, oh, don't make me pronounce it, fostamatinib, or Tavalisse, or Tavalisse? Tavlesse. Tavalisse or Tavalisse? That's the name of it. I'm not making that up. Okay. Let's see. Is there anything else we need to know here? No. Let's keep going. Let's keep moving. Um, client teaching. Client teaching is going to involve the use of stool softeners, maintain a high fiber diet, use a soft toothbrush, blow the nose gently, and notify the healthcare provider of any bleeding. Why is the high fiber diet necessary? Where is that coming from? Maintain high fiber diet. What are we trying to do here? You got it. You got it. Prevent constipation. Very good. Okay, I love it. And then we got the stool softeners on board too. Now, the only thing I don't see on here that I think should be on here is encourage fluids. Okay, encourage fluids. Maintain the water supply. All right, hemophilia. Hemophilia is an X-linked hereditary trait that affects mainly males. Okay, this type of hemophilia almost always occurs in males and are genetically transmitted through the mother. So in this instant, it is the mother's fault. Although the mother does not have the disease herself, she and her female descendants can transmit classic hemophilia to their offspring. Okay? The patient is missing clotting factors that prevent clotting, therefore, the patient has increased risk of bleeding. Acquired, remember we said some diseases are congenital, you're born with, some are acquired. Okay, acquired hemophilia can affect both men and women, but this form of the disease is rare. Okay, clinical manifestations include abnormal bleeding, bleeding in the joint space, which we call hemarthrosis, um, fever, pain, edema, and redness, peritoneum, bleeding into the intestinal wall or the abdominal cavity, and intracranial bleeding. Now, if there's bleeding in the intracranial spaces, a seizure or brain damage can occur. So, again, this is all about safety, right? You might not see it or you might not realize it before we started talking about it, but this is a safety issue. A lot of our interventions are going to be surrounded um, by safety. So, hemophilia is diagnosed by examining factor 8 and 9, which will be deficient. Okay. Care focuses on preventing and treating bleeding and relieving pain. You got to think about it. It's like, well, where did pain come from? Well, if you have fluid in areas where fluid don't belong, it could probably cause some pain, right? So if I have bleeding in a joint, like say my fingers here, I got bleeding in a joint, and there's no room for that extra blood, so it's going to cause some pain. All right, so we want to treat the bleeding, prevent and treat bleeding, and relieve pain. Nursing interventions are going to be aimed at preventing hemorrhage and controlling hemorrhages that occur. So all the things we discussed earlier applies here. Collectively, when we're talking about preventing hemorrhage, collectively, they are known as bleeding precautions. And when we initiate bleeding precautions, we are encouraging the use of electric razors instead of safety blades. We are encouraging the use of soft toothbrushes or the sponges, stool softeners, high fiber diet, and all of those things. Okay? Because we don't want them bleeding. Now, some of our interventions here are control the hemorrhages by applying pressure and cold to the site because cold does what? Vasoconstrict. Very good. Vasoconstrict. Um, Monitor transfusions for factor 8 concentrate. So the doctor's going to order those clotting factors to be administered through a blood transfusion. Do not give aspirin or aspirin products. So this is where reading labels will become necessary. I don't know if you know, but NyQuil has aspirin in it, and many of the other cold medications contain aspirin. So we have to read the labels to see what's in these products. Discuss physical activities within limits and teach weight control. Now, how did weight control get on the list of interventions? How did weight control get on the list of interventions? Remember the joints? Hemarthrosis? Okay, that's how it got on the list. Okay, now we got another one called DIC. DIC is not a disease, but it is a complication of a significant clinical condition that usually accompanies things like severe trauma, gram-negative sepsis, shock, respiratory distress syndrome, RDS, malignancy, transfusion reaction, amniotic embolus, and abrupto placentae. This is the separation of the placenta from the uterine wall. And this is usually when we talk about DIC is when we're in our maternal rotation. But in DIC, the patient is bleeding from every opening in their body. IV site, they're bleeding. Oral, mouth bleeding, vaginal bleeding, rectal, nose, ears, eyes, any opening is bleed. Blood is coming from there. There is excessive clotting to the point where there is no more platelets. So now there is bleeding, right? They didn't use up all the platelets. So plasma clots are formed during this coagulopathy. Okay. Um, what was I getting ready to say? Oh, this leads to thrombosis and eventually bleeding because you're using up all of the platelets. They're using up all the platelets. They can't even stop bleeding anymore. HELP, H-E-L-P stands for um, the H stands for hemolysis, the breaking down of RBCs. EL stands for elevated liver enzymes. EL, or you can think of it as liver enzymes or elevated liver enzymes. But EL is elevated liver enzymes. And remember, we said these clotting factors came from the liver. Okay, all right. But you should be putting it together. I'm breaking it down. You should be putting it together. LP is low platelet count. So HELP is a life-threatening pregnancy complication, usually in preeclamptic um, or abrupte placentae. DIC and HELP usually occur in later stages of pregnancy, or it can occur 48 hours to 7 days after childbirth. So again, we have to teach the patient what to look out for and what to report to the physician immediately. Oftentimes, though, these patients are still in the hospital when DIC rears its ugly head. This is a what we call grave diagnosis. Grave, like the grave, yeah, grave diagnosis, and the prognosis is poor. Anybody who survives this, and I did have a student who um went through this and survived. Actually, did I have two? They are miracles. Okay, because normally people don't survive this. So, and even just telling their stories, um, they well up, we well up, everybody in the class is crying because it's such an experience. I mean, you think you're just gonna go in and have this baby, and just like in the movies, they're gonna bring the baby to you, and that's not happening. Okay, so I like the slide. I like the slide because it explains DIC and you get a visual of what is happening in the body. So let's go over it. Okay, so now we have the pathophysiology here. Um, Hyperactivated coagulation system. Okay, it's hyperactivated. Hyperactivated fibrinolytic. Lytic means to kill off, right? Um, or both simultaneously. coagulation factors and platelets consumed as soon as they are made. So remember, bone marrow is making these platelets. This is part of red blood cells. So they're making the platelets and they've been used up as soon as they're being made. Secondary to an underlying disease or condition, especially, for example, sepsis, placenta abruption, snake bites, that venom, toxin, trauma, graft versus host disease, and burns. So those things, those conditions can trigger DIC. The clinical finding, the patients are at risk of bleeding and thrombosis. So if you look at this picture, you could see that there is a IV site that's just bleeding. Uh, I don't know what that first picture is up there. I can't make it out, but it's bleeding, and then the organ failure. Laboratory findings: thrombocytopenia, prolonged PT, APT, and thrombin time, decreased fibrinogen, elevated D dimers, and then you have the cystocytes on the peripheral blood smear. Okay. The treatment of DIC is to treat the underlying cause. So this is going to involve transfusion, supportive red blood cells, or fresh frozen plasma to replace the coagulate factors. So yeah, I like this picture too. Found it on the internet. It's nice. Okay, so bleeding is the most common sign associated with DIC. Again, the D dimer and FDP is going to be elevated. Fibrin degradation products, FDP. Those are going to be elevated along with the D dimer. International normalized ration, the INR, PT, PTT will all be increased. Hemoglobin and platelets are going to be decreased. So again, medical management is treat the underlying condition. That if that's the placenta coming apart, if it's sepsis, whatever the condition is, that's what you need to treat to stop this from happening. Nursing interventions are aimed at bleeding prevention and careful assessment. Okay, I think this is our last one, sickle cell disease. It's a genetic disorder in which the gene is inherited from both parents. It's homozygous. Okay, a homozygous gene. Sickle cell disease is characterized by gene mutations that cause production of abnormal hemoglobin S rather than hemoglobin A. It is found in 8% to 10% of African Americans, but also affects Hispanics, South Asians, Caucasians from Southern Europe, and people from Middle Eastern countries. However, it is mainly an African American disorder. Sickle cell trait is heterozygous. Sickle cell trait is meaning that the person has an inherited gene for the trait from one parent. Okay, so they got the gene from one parent, but it's not the disease, it's just a trait. So people with the heterozygous trait for sickle cell are carriers. They are carriers. They can transmit the gene to their children even when they themselves do not show signs of the disease. The most common cause of death is acute organ failure from impaired circulation. So I do have a picture of what that looks like. So the RBC elongates, right? It's supposed to be round. Where's my pen? The ooh, the sickles, the RBCs is supposed to be round like this, right? And it's kind of concave. But with sickle cell, the RBC elongates, right? It's not round. Okay. So it's like shaped like a sickle. And it hardens, okay? And O2 levels are low because they don't have that hemoglobin to bind to on this shape. They got it on this shape, but not on this shape. And they have a short lifespan. So recessive is a recessive inheritance disorder, painful crisis, and multiple infarctions occur, and there is hypertension bilirubinemia. Okay. Now, as long as the cells are not causing blockages in circulation, there are no symptoms. It's when the cells clump, blood flow is impaired, and the signs and symptoms of lack of oxygen and blood flow, such as pallor, lethargy, and pain from ischemia, occur. So if you look at this picture, I like this picture too. It gives a good example. If you look at this picture, you can see the normal red blood cells traveling through a vessel, right? The normal red blood cells have, if they cut it across section so you see the hemoglobin in there, right? Okay. Now let's look at the bottom row. Now you got sickle cell going on here. These cells are blocking the expressway. They're flowing and they're running into each other and getting stuck. And if you look at the cross section of the sickled cell versus the normal red blood cell, you'll see way less hemoglobin in there, right? Way less hemoglobin. hmm Okay. So this is what's causing problem. Treatment is focused on prevention of sickle cell crisis and managing symptoms when crisis occurs. And a lot of times this is going to consist of some heavy duty medications, right? So pain control is important during a crisis. They're in excruciating pain. Um, Ibuprofen, NSAIDs, all that kind of stuff does not work. Narcotic analgesics such as morphine, Dilaudid, those type of drugs are administered on a continuous basis, usually by a patient-controlled analgesic pump. I mean, the doctor can order it every 2 hours. That means you're gonna be going in that room every 2 hours when he could just put them on a pump and they can press the button when they need relief. There are many complications of sickle cell disease, including cholecystitis, stroke, pulmonary embolisms, congestive heart failure, and damage to all major organs. But one of the most common problems is leg ulcers from impaired circulation to the legs and the feet. So again, we're trying to prevent infection. We want to maintain adequate fluid intake, avoid alcohol or recreation drugs because what you sickle cell treatment has come a long way from when I first started nursing. But when you're in a hospital, as often as they are taking the type of drugs that they take to manage the pain, when they go home and try to manage the pain themselves, there's you don't get prescribed morphine at home. You don't get prescribed those type of drugs at home. So they usually end up trying to self-medicate to prevent from coming to the hospital. Oxygen is absolutely one of the treatments. They need the oxygen because you saw the decreased hemoglobin in that sickled cell. Blood transfusion with IV fluids is usually part of the treatment plan, analgesics, and adequate rest. Adequate rest. All right, I hope this study group has given you a better understanding of the lymph and blood disorders. Catch me again next Monday as we break down a different topic. I'm Miss Rose, breaking it down. Let us help you reach your goals.